بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we are starting new lectures in the series of musculoskeletal imaging, and we have about 4 lectures about diagnosis of skeletal fractures. And this is a very important topic, as you all know, for both the clinicians and the radiologists. Then we'll go through these lectures, starting first by the upper limb fractures, then we'll go through the lower limb fractures, as well as the types of pelvic fractures. But these lectures will not include the spinal trauma nor the cranial injuries, as they have been mentioned in the specific parts of spinal imaging and neuroradiology lectures. Then starting by some of the definitions, like you need to know that the skeleton contains about 206 bones, and these bones are classified into 5 groups based on the shape. We have the long bones and the short bones, like the metacarpals and metatarsals, the flat bones like those of the skull and the pelvic bones, the sesamoid bones, which are rounded bones located in the tendons, and the irregular bones like those of the sacrum and the vertebrae. And fractures are diagnosed as disruption of the continuity of the cortical and the cancellous bone. Dislocation means that there is disruption of the articulating bones at the level of a joint, and both may coexist in the item of fracture and fracture dislocation when the bone fractures near the joint and the adjacent joint is involved either by subluxation or by dislocation. Then open fracture means that the overlying skin is injured and the fractured bones are exposed to the external environment. The closed fracture means that the overlying skin is intact, and of course this open fracture is more liable for complications like infection and so on. And simple fracture means that there is a fracture line and 2 major fracture fragments. The comminuted fracture means that there are multiple fracture lines and multiple bone fragments. Complete versus incomplete fracture. The complete fracture indicates the fracture line completely crosses the entire bone, while the incomplete fracture, which is commonly known as the green stick fracture, it involves only one cortex of the bone while the opposite cortex remains intact. In valgus and varus deformities, in the varus deformity, the apex is angulated away from the midline, while the valgus deformity means that the apex is angulated towards the midline. And this is an example. In this hip, for example, the apex is angulated towards the midline, and this means that you are dealing with a valgus deformity. Internal and external rotation, this means the direction of rotation of the distal fragment in relation to the fracture line. And medial and lateral displacement means that the fracture edge is displaced towards the midline or away from the midline. Pinot apposition means that there is overlap between the fracture edges, and distraction means that there is a distance or a gap between the fracture edges. And these are the most commonly seen fracture types in the clinical practice, including the transverse fracture, like this one, the oblique fracture, the spiral fracture, and the comminuted fracture, and this is avulsion fracture. I mean, here you got an impacted fracture where the edges are impacted within each other, and a fissure fracture, an incomplete fracture line within the bone, and the green stick fracture, which means disruption of the cortex on one side and the opposite cortex remains intact. And fractures occur according to the type or the mode of loading injury. Like bending loading will produce transverse fracture. Torsional loading will produce spiral fracture. Axial load will produce compression or impacted fracture. Tensile loading will produce an avulsion fracture. The combination of two or more than fracture modes or fracture forces will produce a different pattern of fracture lines. And this is the classic appearance of the incomplete fracture. We have two types. They are occurring mainly in the pediatric age group. The green stick fracture, where there is disruption of a single cortex and the opposite cortex remains intact. The torus or a buccal fracture, which usually occurs in the metaphysis due to axial load with axial compression, resulting in this appearance. And there is impaction of the cancellous bone, but you cannot actually identify a specific fracture line. The combination of both types may occur in a single patient. And the stress fracture is the fracture which is produced by repetitive traumatic forces to a certain part in the body. They are classically seen in the proximal part of the tibia, in the second metatarsal bone, and in the femoral neck. This is a commonly seen fracture in runners, where you got an insidious fracture in the second metatarsal bone. The fracture heals with a prominent amount of callus, as you can see here. And the stress fractures of the femoral neck are usually treated by surgical stabilization. I will mention this in details in the part where we deal with fractures of the lower limb. And groin pain in runners raises a high index of suspicious of fractures of the femoral neck. And pathological fracture is the fracture occurring on top of a pre-existing bone pathology. And here you can see an osteolytic lesion in the distal part of the radius, representing let us say simple bone cyst, and there is a fracture across the diseased bone, and this is pathologic fracture. Intra-articular fracture is a very important type of fracture which involves the articular surface of the bone. And you know that this fracture is usually complicated by joint involvement, and there may be some loss of function of this joint or the development of early osteoarthritic changes. Then the basic goals of treatment of these fractures should include accurate anatomic reduction, rigid fixation, early motion, and if this is in the lower limb, you ensure progressive weight bearing to maintain the function of the joint. And you will know the Salter-Harris classification of the fractures occurring before the epiphyseal union. And we have 5 types. This is the normal appearance of the epiphysis, the physis, and the metaphysis. The type 1 means that there is a separation or widening of the physis, and this is a nice way to remember these types of fractures by the name of the Salter-Harris who developed this classification. Then the type 1 means that a straight fracture across the physis with widening of the physis. The type 2 means that the fracture occurring above the physis. Type 3 below or lower to the physis. Type 4 through the physis, above and below. Type 5 means the impaction through the physis, compression or crush or erasure through the physis. Then we came to an important issue, which is the complications of fractures. And you know that the major complications are belonging to the union. We may have malunion, delayed union, and non-union. And then sometimes there may be a pseudoarthrosis or false joint develops as a result of a non-union. If you look here and you see an example of malunited fracture. This fracture involves the femoral shaft. There is overlapping of the fracture edges, and there is complete union with callus formation, but in a malposition. And we have 2 types of non-union: the hypertrophic non-union and the diatrophic non-union. And hypertrophic non-union means that the patient has, or the body has, the ability to for union, but the fracture is inadequately immobilized, and then there is a continuous movement at the fracture edge, which is preventing union in spite of adequate callus formation at the site of the fracture. While the atrophic non-union means that the body lacks the biology to heal. Then hypertrophic non-union usually requires a stable fixation, while diatrophic non-union usually requires bone grafting or internal fixation or ultrasound stimulation to stimulate the union process. And this is a non-united fracture of the distal end of the fibula and the radius, diagnosed by the fracture edges are still seen, and they appear sclerotic with a scanty callus formation at the fracture site. Then one of the complications is stiffness and loss of motion, and this is usually occurs in cases of intra-articular fractures involving the adjacent joint, usually due to the development of bleeding inside the joint and the development of fibrosis inside the joint, secondary to a long period of immobilization, and this may be also initiated by loose bodies inside the joints, nerve pulses, and inflammatory changes in the adjacent joint. Avascular necrosis is one of the post-traumatic complications They are commonly seen in the femoral head in cases of femoral neck fracture, in the talus, and in the scaphoid, especially in the scaphoid waist fractures, as I will mention. Then infection of the fracture or the adjacent joint increases in cases of open fractures and closed fractures treated operatively, the use of implants, and the presence of dead necrotic bone. And this is a very important issue, which is the post-traumatic myositis ossificans. This is a benign process which is characterized by high heterotopic ossification, usually in the large muscles. And in the type of myositis ossificans circumscripta, there is usually a history of significant trauma. But there are other types of myositis ossificans, like the myositis ossificans progressiva, which is an inherited disorder characterized by fibrosis and ossification of the muscles, tendons, and the ligaments at multiple sites without any known history of trauma. Panniculitis ossificans is that lesion occurring in the subcutaneous tissue, and the pseudotumor of the digit is a variant of myositis ossificans occurring in the digits of the hands and feet. But we are talking now about myositis ossificans occurring post-traumatic. This lesion affects usually the large muscles, and commonly seen in the anterior aspect of the lower limbs, which is the site more prone for frequent trauma. The patient may present by painful, tender, enlarging mass, and it will appear by the plain X-ray as an area of ossification or calcification and in the soft tissues, usually along the shaft of a long bone. Then here you see a patient with total knee replacement with a development of a bony mass along the anterior aspect of the femoral shaft. Calcification begins to appear on the plain films within 2 to 6 weeks of the trauma or the surgery. The lesion reaches the classic appearance by 2 months. Then during the following 4 months or so, the lesion becomes smaller and dense. What's very important is the presence of a cleft or a radiolucent line separating the bony mass from the shaft of the adjacent bone, and this cleft is known as the string sign. And this string sign is one of the criteria of myositis ossificans. And in the early phases of myositis ossificans, it will show tracer uptake in the early and delayed phases. But when the lesion is completely formed, the delayed uptake or the uptake on delayed phase imaging is one of the typical findings. Then myositis ossificans is easily diagnosed by the plain film and also by CT, but on MR images they are usually mistaken for soft tissue tumors because they behave like any of the soft tissue masses. They appear of low signal in the T1 and the high signal in the T2, and if you give contrast they will enhance. Then the early features of myositis ossificans are indistinguishable from tumors. They appear ill-defined, iso-intense to the muscles on T1. They show increased signal and T2 weighted images, and if you inject contrast they will enhance. Then it is usually stated in the literature, this statement, you see a bony mass in the plain films and on CT images, but on MRI T2 weighted images they show bright signal, and they also show enhancement on T1 weighted image. This is the T1 you see this lesion ill-defined within the anterior thigh muscles, and this T1 post contrast with fat suppression, they see enhancement of the lesion. Then also the implants may be prone for fractures, like the bones, and many times you can see what's known as implant failure, where you got fracture of the nail or dislocation of the screws in many times. One of the important issues, it will be discussed also many times in separate issues, is the complex regional pain syndrome, or the reflex sympathetic dystrophy, or the previously known Sudix atrophy. This lesion appears usually following a minor trauma to a certain part of the body, usually the hand or the foot. And the resultant, this trauma will result in severe swelling of the limb, and marked erythema and redness, and the extreme tenderness even on touch. And if you see this in a patient with minor or relatively mild trauma, then you diagnose this syndrome, which is known as complex chronic regional pain syndrome, or reflex sympathetic dystrophy. The mechanism of this syndrome is unknown, and there are many factors which are accused as underlying causes. The treatment is by sympathetic blocks and aggressive physical therapy. Satellite ganglion block are used for involvement of the upper limb, and epidural blocks and lumbar sympathetic chain block are used for lower limb lesions. And these are the supposed underlying causes of this syndrome. In many cases, the cause is unknown. The trauma is one of the causes. CNS disorders, myocardial infarction, and sometimes immobilization. Then if you look here, and you see that the hand is red, swollen, and it's very tender or painful. And on the X-ray, you can see extensive osteoporotic changes surrounding the area involved, as you can see here in the proximal part of the metacarpals, the carpal bones, and the distal parts of the radius and ulna. Then also one of the complications is vascular injury, and those which are commonly injured are the veins, while the arteries are less frequently injured since they are elastic and mobile. This will result in the hematoma surrounding the fracture, and the fractures of the clavicle, the supracondylar fractures of the humerus, and the knee dislocations are examples of traumatic lesions commonly associated with vascular injury. And we also do not forget the pelvic fractures, which are in many times associated with significant bleeding. And compartment syndrome is one of the complications of fractures, where a certain muscle or a group of muscles which are isolated in a certain compartment are subjected to trauma. The trauma will result in muscle edema. Muscle will swell, and because it is entrapped in an isolated compartment, the muscle is unable to expand. Then it will develop rapidly necrosis, and this is meant by the compartment syndrome. The earliest sign is severe pain with passive muscle stretch in the involved area. The involved area is commonly in the anterior part of the leg, and the muscle commonly involved is the tibialis anterior muscle. This is because this muscle is an isolated compartment bordered by the tibia and the fibula, posteriorly by the interosseous membrane, and anteriorly by the skin. If there is injury to this part, and then the tibialis anterior will try to enlarge or to be swollen, then this limited space will not enable the muscle to enlarge, and it will develop rapidly muscle necrosis, and this is known as compartment syndrome. Here you see the normal limb and the involved limb, and this is T1 weighted image, and this is T2 weighted image, and this is T1 post contrast. Here you see that the muscle is relatively swollen compared to the normal one, and it has heterogeneous signal with increased T1, meaning that there is some edema and hemorrhage. And also in the T2 weighted image, and you can see also fluid in the subcutaneous area with if you inject the contrast material, you see that there is some enhancement, while the starting necrotic tissue will not enhance. And this is an example of calcific myonecrosis, where this is a rare post-traumatic complication, and you see the muscle in the anterior aspect of the thigh is markedly swollen and liquefied with dystrophic calcification along its edge. And many times you are confronted by a patient who is complaining of pain in a certain muscle group, and you perform an MRI and you can see absolutely normal finding. Then this is known as chronic exertional compartment syndrome, and you will see the lesion only after stress. Like you can see the lesions of the cardiac muscle by the stress echo or the stress Saliam technique. Then you let the patient the patient to perform the exercise, and when he develops pain, then you do the MRI, then you will see the abnormal signal and somewhat swelling of the involved muscles. This will regress totally when during rest. And we have finished with this introduction, and now we are going to discuss the fractures affecting the upper limb. We will discuss some of the phalangeal fractures, including the gamekeeper thumb, boxer fracture, Bennett fracture, Rolando, epibasal, and interphalangeal joint dislocations. Then we'll have some notes about the carpal bone fractures, especially the scaphoid, the triquetral, peri-leonate dislocation, capitate, pisiform, and hook of Hammett. I think by this we will end the first part of this lecture. Then in the second part we'll continue by the forearm fractures, including the green stick and torus fractures, Cooley's and Smith, and Galeazzi, Monteggia, radial head fractures, and olecranian fractures. Then we'll have some words about elbow joint dislocation, supracondylar humeral fractures in children and in adults, proximal humeral fractures, and finally we'll end by shoulder joint fractures and dislocations, including clavicular fractures, acromioclavicular separation, and glenohumeral dislocations. Then we'll start first by the phalangeal fractures, and this is known as gamekeeper fracture or a square thumb. This is a common and frequently missed injury because it is usually not associated with fractures. It occurs in the metacarpophalangeal joint of the thumb by injury of the ulnar collateral ligament. And you know, here there is an ulnar collateral ligament, and this is the radial collateral ligament. This injury is a valgus injury occurring during football, and the trauma will result in damage of this ligament, maybe associated with a small ship of a bone fragment at the base of the proximal phalanx. Then this is the anatomy. This is the ulnar collateral ligament, this is the radial collateral ligament, and the aponeurosis of the adductor and abductor pollicis muscle. An injury which is a valgus type of trauma. There is rupture of the ulnar collateral ligament, and sometimes with avulsion of a shape of bone in this area. And this is a lesion which is usually diagnosed by MRI. This is the radial collateral ligament which is intact, and this is the ulnar collateral ligament which is ruptured. And the adjacent image shows the normal anatomy. This is the ulnar collateral ligament, and this is the radial collateral ligament, and this is the adductor aponeurosis. Then we came to the second fracture, which is the boxer fracture. It usually involves the fifth but may involve the fourth metacarpal bone. And this is an example of boxer fracture affecting the fourth metacarpal bone. And this is an example of a fracture involving the fifth metacarpal bone, and this is the way how to fix this fracture. That Bennett fracture is an intra-articular fracture of the base of the first metacarpal bone. And this is a two-piece fracture. And you see a separated a small bone fragment at the medial aspect of the base of the metacarpal bone of the thumb. And this fracture extends to involve the articular surface of the bone. Then involvement of the articular surface is a serious injury and requires adequate reduction, adequate fixation, early mobilization, so that to prevent joint the complications. As I have mentioned, this is a two-piece fracture, a small piece and large one. It involves the articular surface, and it is slightly dislocated, as you can see here. And, it affects the medial aspect and reaches the articular surface. And this is an example of a classic Bennett fracture by X-ray and by CT scan. This is the metacarpal bone, and this is the fracture line. Then we came to fractures occurring in the same area but with different names and different prognosis. The Rolando type is a three-piece fracture, as you can see here, three-piece fracture. It is in the form of V or Y shape, the fracture. It affects the articular surface of the base of the first metacarpal bone. Then the third type is known as epibasal, and this is this fracture occurs away from the articular surface. It does not affect the articular surface. And this is an example of an epibasal thumb fracture affecting the base of the first metacarpal bone, and it does not reach the articular surface. Then interphalangeal dislocations usually affect the proximal interphalangeal joint, and the dislocation is usually dorsal, and the pattern of trauma is hyperextension injury. Then all what you need to know is the level of the dislocation and the direction of dislocation, and this is posterior or dorsal dislocation of the proximal interphalangeal joint. And if you look carefully in the frontal view, and you see there is some lateral displacement as well. In this head of the phalanx, seems as if it is protruding outside the confinement of the skin, meaning that it may represent an open injury. Then here is the dislocation of the proximal interphalangeal joint, which is commonly dorsal and commonly affecting this joints and due to hyperextension injury. Then we came to the famous scaphoid fracture, which is usually the result of a fall on the outstretched hand, and it affects the waist of the scaphoid bone. And this is one of the fractures that may be missed if you perform the X-ray immediately after trauma. But if you wait for some time, you can discover the fracture line. Then, as I have mentioned, it results from a fall on the outstretched hand, and clinically there is tenderness in the anatomic snuff box, which is considered the diagnostic sign of scaphoid fractures. This is, I have mentioned just now, if you have an X-ray immediately after injury, you may fail to see the fracture line. But after that, you are able to see. Of course, CT scan and MRI are more sensitive than the plain X-rays in detection of these fractures. And this is an X-ray of the wrist showing a non-displaced scaphoid waist fracture. You know that the blood supply to the scaphoid bone is entering the scaphoid from its distal part. Then the fracture will prevent the blood supply reaching the proximal bone, and this part of the bone is very liable for a vascular necrosis. Then this is a pathologic fracture of the scaphoid bone. You see an osteolytic lesion in the scaphoid, like a simple cyst, for example. Then after trauma, there is fracture across this cyst, so we consider this as a pathologic fracture. And by CT, you can appreciate the fracture line across the scaphoid bone, and also you can appreciate minor degree of relative bone sclerosis of the proximal bone compared to the distal part of the scaphoid, meaning that there is a developing a vascular necrosis in this part of the bone. And sometimes you got a scaphoid tubercle fracture, which is not seen usually in the frontal view nor in the lateral view. It is usually seen in the oblique view, and this is what we call a scaphoid tubercle fracture. And this fracture may be missed in up to 30% of the cases examined by plain radiographs. And by MRI, then it is easy to see the fracture line across the scaphoid bone, and you see the diffuse bone marrow edema showing low signal in the T1 and high signal in the T2 weighted images. This fracture of the scaphoid waist with developed vascular necrosis identified by the sclerosis of the proximal part of the scaphoid, and this is the usual way of management of scaphoid fractures is in order to prevent vascular necrosis is to perform internal fixation and to initiate joint movement as early as possible. Then we came to the tricateral fracture. You know that the first row of the carpal bones include the scaphoid, the lunate, and the tricaterum. And this tricaterum is considered the second most common bone to be fractured, of course, after the scaphoid bone. and the fractures are usually in the form of avulsion from its dorsal surface. So they are clearly identified in the lateral view of the wrist joint as a ship fragment located posteriorly, and this fracture is frequently missed in the frontal and oblique views. And in the frontal view and oblique view, this fracture is usually superimposed by the basiform. So it is clearly identified in the lateral view. The body of the triquetrum may also be fractured, and this is perfectly seen by the CT scan, and also the triquetral fractures are involved in this well-known type of dislocation, which is known as the perilunate dislocation. I will mention in a moment. And in the frontal view, it's difficult to appreciate fracture of the triquetral bone. In the lateral view, you see this avulsion fragment of the triquetrum. Then we came to the perilunate dislocation, which are 2 to 3 times more common than lunate dislocations itself. Then first of all, what are the bones adjacent to the lunate? Then you see here, this is the lunate bone, and radially you can see the scaphoid, and on the medial aspect you can see the triquetrum, and anteriorly and you see the capitate. Then the perilunate dislocation will involve these bones, the scaphoid, the triquetrum, and the capitate. 75% of these dislocations will be associated with scaphoid fracture. Whenever these the relations are disrupted in the rest, then you got what is known as crowded corpus. And this crowded corpus, and you see here the carpal bones are usually arranged in a nice way like this, but in the frontal view you see that the carpal bones are as if they are superimposed on each other. Then we have mentioned that there are 3 bones involved in the perilunate dislocation: the scaphoid, which is fractured in 75% of the cases, the triquetrum, and the capitate. Then the triquetral fracture is usually identified in the lateral view as a ship fragment. And the rest of the fractures, especially those of the scaphoid bone, are usually seen in the more sophisticated imaging techniques like the CT scan, for example. And this is an example. You should remember that in perilunate dislocation, the lunate is not dislocated. The lunate remains in its normal apposition and articulation to the radius. What is dislocated are the bones around the lunate, including the capitate, which is dislocated posteriorly, and the scaphoid, which is fractured and into 2 segments. The proximal pole will remain in relation with the lunate bone, while the distal part of the scaphoid bone will be displaced dorsally with the displaced capitate bone. Then, in order to diagnose perilunate dislocation, you have 3 major findings. Number 1, the crowded corpus or the crowded carpal bones. Number 2, the fracture of the triquetrum. Number 3, the dorsal displacement of the capitate. Number 4, the fracture of the scaphoid bone. And you know that the capitate and also the triquetral may be fractured, isolated from other carpal bones, and this needs the CT scan for detection. And this is the capitate, and you see the transverse fracture line in the sagittal and the coronal reformatted images. Also, fractures of the basiform are considered rare or unusual, and they can be seen by the plain film. If you look carefully to the basiform, then you see the fracture. And the hook of hamate is one of the fractures of the carpal bones. You remember that the flexor retinaculum covering the carpal tunnel is stretched between the hook of hamate and the tubercle of the trapezium. This is the trapezium, trapezoid, capitate, and hamate. Sometimes this hook of hamate is fractured, and it is one of the causes of carpal tunnel syndrome. Then one of the good landmarks for diagnosis of fractures of the hook of the hamate is loss of the eye of the hamate. Then if you look for the normal wrist bones, and you see this is the hamate, and this is what is meant by the eye of the hamate. It is usually seen in all frontal projections of the normal wrist joints. But whenever the hook of the hamate is fractured, then you got loss of the eye of the hamate. And this is one of the, if you look here and you can see the fracture, but the fracture is well appreciated on CT and MRI images. In this frontal radiograph, and you see that the eye of hamate is not clearly identified, and the CT scan of the same case shows fracture of the hook of the hamate. And this fracture can be also demonstrated by reformatted images. This is the axial image with hook of hamate fracture, and this is the sagittal reformatted images, and they say the non-displays the fracture of the hook of the hamate. Alhamdulillah Rabbil Alameen. Thank you very much.